Good evening and welcome to our webinar, ADHD and Tourette Syndrome. My name is Angela Sullivan, Medical Project Specialist, and I will be your moderator for this evening. This webinar is being provided as part of the Tourette Health and Education Program, a program of the Tourette Association of America in partnership with the CDC. During tonight's webinar, we would be very happy to hear from you and include your voice in the conversation. You may ask questions or share comments using the question panel on the right side of your GoToWebinar player at any time. We will collect your questions and address them during the Q&A session at the end of the presentation. I would like to mention that funding for this webinar was made possible by our cooperative agreement with the U.S. Centers for Disease Control and Prevention. The views expressed by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsement by the U.S. government. So tonight it is my pleasure to introduce you to our speaker, Dr. Max Wiznitzer. Dr. Max Wiznitzer is a pediatric neurologist at University Hospitals, Rainbow Babies, and Children's Hospital in Cleveland, Ohio, and professor of pediatrics and neurology at Case Western Reserve University School of Medicine in Cleveland. He is board certified in pediatrics and neurology with special qualification in child neurology and neurodevelopmental disabilities. Interests include attention deficit hyperactivity disorder, autism spectrum disorders, developmental and behavioral disorders, and pediatric stroke. Dr. Wiznitzer has authored or co-authored 11 textbook chapters and over 80 scientific papers, is on the editorial boards of Lancet Neurology and Journal of Child Neurology. He is a member of the American Academy of Pediatrics, the American Academy of Neurology, the Child Neurology Society, the Society of Developmental Behavioral Pediatrics, and the International Society for Autism Research, a member of the Neurodevelopmental Disorders Committee of the American Board of Psychiatry and Neurology, and past liaison to the Developmental Behavioral Pediatrics Subcommittee of the American Board of Pediatrics. He is also co-chair of the Professional Advisory Board and member of the Board of Directors of CHADD, Children and Adults with Attention Deficit Hyperactivity Disorder. So without further ado, Dr. Wiznitzer, please go ahead with your presentation.
Thank you for that kind introduction, and thank you for everyone for attending this webinar. And let's just get on to the topic, which is diagnosing and managing ADHD in individuals with Tics and Tourette Syndrome. As usual, we have to give our disclaimers here, and just to let everyone know, as it was stated before, I'm a member of the CHADD Board of Directors. CHADD is the National Advocacy Group for ADHD, and working together with Tourette Association in this presentation. And I'm also the co-chair of their Professional Advisory Board. I will discuss what's called off-label treatment options, which really means some of the medications have not been FDA approved for the management of ADHD, but have been shown in research work to be effective. So let's look at ADHD. Simple point. It's the most common behavioral disorder of childhood. It occurs in about 3 to 10% of children. Probably a conservative number is about 8% of children. It's interesting that the description that's given is more boys than girls are symptomatic in the childhood years, but when you look at the adult years, it's about a 1-to-1 ratio equal between men and women. And ADHD usually does not go away, either can persist in its full syndromal form, which means symptomatic form, or features of it may persist even into adulthood and may affect the functioning of individuals. ADHD has a fascinating history. It's been around for a long, long time, and it's gone through a variety of names. In 1902, it was given the name of morbid defect of moral control. In the 1940s, it was given a label of minimal brain damage until research work could find no evidence of overt damage to the brain. Then they call it minimal brain dysfunction. When the Diagnostic and Statistical Manual of the American Psychiatric Association was developed, it went through various name permutations: hyperkinetic syndrome of childhood, then ADD with or without hyperactivity, which is where the differentiation between the term ADHD and ADD first occurred, but that really is a misnomer. It is not really an accurate description. ADD and ADHD are really under the same umbrella and may describe the same individual at different times in their lifespan. We'll talk about that a little bit later. And more recently, since 1987, we've used the term ADHD, including in the most recent iteration of the Diagnostic and Statistical Manual, the 5th version that came out in 2013. When we look at ADHD, the vast majority of individuals with ADHD have it because they're born with it. And when they're born with it, it's thought to be genetic, although specific linkages to genes has not really been as well established as we would like. In addition to the genetic predisposition, there can also be environmental factors. For instance, exposure of the fetus or unborn baby to excessive alcohol during pregnancy can cause damage to the brain and cause that child to have ADHD features as part of the fetal alcohol syndrome presentation. Also, we have to take into account the individual's temperament. Not everyone is laid back. Some individuals can be slow to warm up, and other ones can be described as difficult children. And of course, the manifestations can vary depending on the individual's age. I'll show you a slide about that, as well as the overall intelligence of the individual. There are other factors from the environment that can influence the children with ADHD and either lessen the severity or increase the severity of the presentation. That includes influences by peers, the neighborhood in which you live, as well as the ability to access medical care for the condition. In the home setting, the type of discipline methods that are used, whether people use a positive parenting approach or a punitive punishment approach, can easily influence how that individual with ADHD will continue to show the features of ADHD as they get older. In addition to that, how the family is structured, and what kind of support services are in place, and how good the caregivers are in terms of managing a child with ADHD. As we know, children with ADHD can be very difficult to manage, as one of my parents told me today during the office visit, and we have to recognize that that is in play when we basically manage the individuals. Now, when we look at the diagnostic criteria for ADHD, no matter where you look and what you say, the functioning of that individual is not appropriate for their developmental level. The attention span of a 5-year-old with the intelligence of a 5-year-old is not at a 5-year-old level. The attention span of a 5-year-old who has the intelligence of a 3-year-old is not at a 3-year-old level. They have problems paying attention, they have problems with motor overactivity, and they have problems with impulse control. By definition, the onset of the ADHD has to be present prior to age 12 years, and frequently some features are present during the preschool years with full manifestations during the early to mid-school years. The features of ADHD have to be present for at least 6 months. It can't be just an acute reaction to some stressor in the environment. It can't be that they're on some medication that's provoking those behaviors. It's something that's happening from within this individual, in this case the child, and shows itself and continues to be symptomatic in a waxing, waning manner for 6 months. And they have to be symptomatic in more than 2 settings. It can't be the individual's not paying attention because the class is boring. It can't be the individual's not paying attention because they're in a stressful environment. It has to be that they're symptomatic at home, at school, in the work setting, at the neighbor's home, and it causes problems with socialization, with academic performance, and with work performance. Now, when you look at the criteria for ADHD, they really haven't changed in the last 2 iterations of the Diagnostic and Statistical Manual. When you look at the criteria for inattention, there are 9 core criteria that have been shown in field testing to identify the children with ADHD. Now, there's some crossover between these, but we're not here today to talk about the individual validity of each of these diagnostic criteria, but just an understanding that when we make a diagnosis of ADHD, we're just not doing something willy-nilly. We're really doing things in a manner that has been scientifically validated. And in this case, for children, you need to have at least 6 of the 9 criteria present and causing symptomatic impairment. For older adolescents and adults, you have to have 5 of the 9 criteria that are present here, and we have to interpret them as appropriate for their developmental level and their age. In the same way, when we look at the hyperactive impulsive criteria, you can see that the terminology that I use, which is motor overactivity, probably is a better descriptor than hyperactivity, because the child may just fidget or squirm in a chair. An adult may just complain of internal restlessness, but it appears to be able to sit still, but occasionally has to get up and move around. Not only are they overactive physically, but they can also be overactive verbally, which is what talks excessively is one of the criteria, and they have problems with impulse control. And again, in these criteria, 6 of 9 for children and 5 of 9 for the adult population are needed in order to make a diagnosis. And that means that you have to have these features that are more likely than not impairing functioning on a regular basis in multiple settings. Now, when we look at the presentation of these individuals, it depends the age at which we evaluate them. So if we look at preschool children, the way they typically show up is by being very overactive, very impulsive, and frequently temperamental, oppositional, defiant, and really stressing everyone around them. By the time they get to the school years, they have more academic, if they're presenting for the first time in the school years, there's not as much of the disruptive behavior that's there as is difficulties with school performance in terms of their academic work, doing the work, learning the lessons, turning the work in, being difficult with peers. One of the parents told me today that her son annoys his classmates all the time, has difficulties maintaining relationships with the peers simply because the ADHD behaviors get in the way. They daydream, they can't wait their turns. And at that age, you can see that these kids are not at the same social level. Many of these children are socially immature. By definition, it's about 2/3 of the calendar age is usually what the social age is during childhood. When you get to the teenage years, the hyperactive features have really diminished, but the impulsivity persists, the inattention persists, and the impulsivity can manifest in making poor decisions, risk-taking behaviors, errors with driving, inappropriate actions that get them into trouble with the authorities, sexual behaviors and relationships without thinking of the consequences, fighting with authority figures. It gets you into trouble, and it continues into the adult years, as is listed here, with not problems finding a job, but problems keeping a job, problems with relationships, problems paying attention, being organized, with time management. And you can even have temper outbursts that occur in individuals who have problems with impulse control. When we look at the ADHD features, as you can see from this table, individuals typically show some of the features of ADHD by the late preschool years, typically by age 3 to 5 years. Tics, on the other hand, don't show themselves until the school age years. Classically, the first tic may show up somewhere between 6 and 8 years of age. That means that there's going to be an overlap between the presentation of tics and the presentation of ADHD. And I want you to remember that, because this was one of the reasons why people initially thought that the medications used for the management of ADHD truly aggravated tics or brought out tics in individuals who didn't have them. Associated features of ADHD, because of the impulsivity, because of the frustrations that occur in relationships and with performance on a daily basis, include behavioral outbursts due to frustration, being bossy and stubborn because you want your way, you're perseverative, you nag, you want to get what you want, you insist that things be done the way you expect them to be, all of which gets you into trouble. The consequences for the individuals is that they develop poor self-esteem, a poor self-image, they may get demoralized. The hyperactive, impulsive children will get rejected by the peers because they're too intrusive. The individuals who are predominantly inattentive may just be more daydreaming, and peers may not pay attention to them. It affects school performance. It affects work performance because of the insistence of wanting what I want. You get into fights with family members. You get into fights with school personnel. You don't do the work as best as you can do. You don't apply yourself the way you can. And basically, you develop antagonistic relationships in multiple settings. Now, this is untreated ADHD. When we look at ADHD, if you have both the hyperactive impulsive and the inattentive type, by definition, that's called combined type. And of course, if you have one predominating and the other one not as symptomatic, the labels change to either predominantly inattentive or predominantly hyperactive impulsive type. These labels are applied at the time that the child is evaluated and should be re-examined periodically, because as individuals get older, the label may change. So for instance, in the preschool years, because of difficulties measuring the inattentive features, the children may be labeled as ADHD, predominantly hyperactive impulsive. When they get into the school age years, then they get called combined type as the inattentive features become more apparent. As the hyperactivity diminishes in the adolescent and adult years, they may be labeled as predominantly inattentive. Now, we're not dealing with a different person. We're just dealing with the same disorder showing itself in somewhat different ways as the individual matures. It's something that we have to remember. Now, when we look at the complications of ADHD, in the preschool years, there's a lot of oppositional defiant behaviors. There's learning problems, there's language problems that they can have. In the school age years, in addition to that, they can develop behavior issues, which if they include breaking the law, it is called conduct disorder. By the adolescent years, as your self-esteem goes down, your mood may go down. You have risk-taking behaviors, increased risk of drug use, especially individuals who are not adequately treated with ADHD. And in the adult years, you may actually end up into criminal behaviors that occur. Anxiety can be present at any time during this time as one of the coexisting conditions. And of course, there's also problems with interactions with familiar individuals. There are conditions that coexist with ADHD: anxiety disorders, mood disorders, especially bipolar disorder, language problems, learning problems. Sleep problems occur in a large percentage of these children and are erroneously blamed on medication. But if you take a good history, many times you find out that the sleep problems pre-exist. They exist before the time that any medication was started. I had a parent say the exact same thing to me today, that she said to me, the medication didn't seem to alter the disturbed sleep patterns that the child had. Of course, tic disorders can be associated with it. The description that's given is that about 10 to 12% of individuals with ADHD will have a tic disorder or have Tourette syndrome that's there. And we'll talk about the other relationship in a smidge. About 50% of individuals with ADHD have problems with their fine or gross motor skills and motor planning skills, known as developmental coordination disorder. And as individuals get older, you can see that they have problems with executive functions. Executive function is basically the brain secretary. How we do things, how we run things, how we get things done. How good is our time management? How good is our organization? How good are we at really planning our day and doing and finishing projects that we've started? These are all difficulties that can be present in this population. When you look at ADHD and Tourette syndrome, interestingly, from a clinical standpoint, the ADHD and Tourette syndrome looks the same as the ADHD and children who do not have Tourette syndrome. The same diagnostic criteria, the same features. ADHD, depending on the population we're looking at, occurs anywhere between 30 to 90% of children and individuals with Tourette syndrome. However, one of the things that we have to be careful about is we have to differentiate the inattention of ADHD from the inattention and the distractibility that occurs in individuals with Tourette syndrome, because their own tics are basically distracting them. The tic is occurring, they're trying to inhibit it, they're trying to stop it from happening, and that distracts them from what's going on around them. In addition, individuals with Tourette syndrome have an increased rate of anxiety and OCD, both of which can also affect attention span. So one of the things we always have to do in these individuals is differentiate between these features that might be causing the inattention from the ADHD that is causing the inattention. Interestingly, when you're looking at the challenges that occur in the children and young adults who have ADHD and Tourette syndrome, it's mainly the Tourette syndrome, it is mainly the ADHD that is driving the behavior. The ADHD is found to be responsible for the aggression, the rage, and the mood instability. unless you're really taking into play the anxiety and OCD. And even there, the impulsivity from the ADHD is clearly contributing. And also the problems with organization, with time management are all related to ADHD. So it's important to recognize the ADHD and Tourette syndrome and to treat it adequately in order to make sure that individuals with Tourette syndrome have good functioning. Now, when you look at reasons for why ADHD is, in about 80% of the population, we believe it's genetic. It runs in the family. Almost anything that can injure the brain and leads to identifiable brain injury, whether it's lack of oxygen to the brain trauma, whether it's infection, whether it's an external toxin, or it's an internal problem such as low blood sugar or certain substances that the body makes, or a stroke, any of these things can actually cause you to have ADHD presentation. In addition to that, certain medications that we prescribe as physicians can cause children to become disruptive, inattentive, and very impulsive. So we always have to make sure that it's not the medicine that's doing it, it's something innate to the child. But these are things that we have to look for. In the Tourette syndrome population, it basically falls probably within the idiopathic genetic formulation, since we know that tics can also run in families. There's a differential diagnosis to attention problems. It's listed here. There's a variety of psychiatric problems such as mood disorders, anxiety disorders that can also cause inattention. If you don't get a good night's sleep, if you have a very low IQ and no one recognizes it, if you have a learning disability so you don't understand what's going on, if you have problems with your hearing or with your vision so you either can't hear or can't see what's happening, all of them can make you not pay attention quite well. If you have a certain seizure disorders, they can make it look like you're daydreaming. Obviously, if you're neglected or abused, or if you're a difficult child, that can impact your ability to interact with your environment and make it look like you have ADHD. All these factors have to be taken into account before the diagnosis is made. When the diagnosis is made, it's made using specific rating scales. We have checklists that are put together. It's a clinical diagnosis, so it's checklists that are put together that you can identify the features that are present in excess in order to make the diagnosis. Neuropsychological testing can be helpful to identify coexisting learning problems and can also be part of the evaluation when appropriate. Observations have to be done in multiple environments. For the children that I take care of, I typically get feedback from the home, I get feedback from the school, I get feedback from the babysitter or the daycare. When they're older, you can also get feedback from the work environment or from peers with whom they work. All of this can be very helpful. For ADHD, even though the features may fade by adulthood, many individuals still have some symptomatology. Undertreated ADHD leads to difficulties with reading, less years of education. They don't graduate. They have a lower graduation rate, for instance, from college. Many of them don't make it through college and shift. They can get jobs, but they have difficulties keeping jobs, and the kind of job that they get is not really at the level of that individual's capabilities. It can impact socialization, and there's an increase in the comorbidity. There's actually also problems with life expectancy. There's a significant shortening of life expectancy in individuals with ADHD due to a variety of reasons, which includes the impulsive behaviors, as well as developing adult disorders such as hypertension, diabetes, and not being able to adequately manage them. So ultimately, ADHD turns out to be a public health issue with the idea that treatment may reduce the risks. So if you're going to treat the ADHD in a Tourette syndrome individual, what should you do? One is it has to be a team effort. Everyone has to work together. Not the patient, the family of the patient, school or the work environment has to contribute, as well as the clinician. Everyone has to be an informed consumer. You have to know what you're doing and why you're doing it. A parent today said to me, my son's in college. These college teachers don't know ADHD. They ascribe his ADHD behaviors as being willful disobedience or just laziness with not a good understanding. So that means they need to be educated and understand. Families need to understand what needs to be done. that individuals in the work setting need to know what should be done, and individuals in the school setting should know what should be done. And you need to have a multimodal intervention, behavioral interventions, educational interventions, as well as medical interventions. We know that the type of intervention differs amongst the individuals. People write about the management of ADHD in individuals with Tourette syndrome. If you have mild to moderate ADHD, some individuals state you should first try behavioral interventions, and I'll go into that in a little bit. Behavioral includes educational. Moderate to severe, medication may be quite useful. If you have a combined treatment regimen where you're using a medication plus behavioral and educational treatments, you can also manage the conditions that don't respond to medication, such as the learning challenges that occur in that population. You can also address other conditions such as the anxiety and OCD that we see in Tourette syndrome. We can also treat the tics and reduce the impact on the individual's daily functioning. What does this do? It actually leads to a lessening of the medication amount that you need for ADHD management. In other words, if all I'm doing is just giving a medicine and nothing else, I'm doing nothing else, most of the time you have to use a higher dose of medicine than if you have a combined package in terms of the management. Monitoring the functioning, you have to get feedback. You can look at report cards, which is what I usually do. Most of my patients come in and show it to me because they've gone from C's and D's to A's and B's, which is an obvious positive effect of the intervention. There's also formal rating scales that can be used to monitor the response to the medications and response to the educational and behavioral interventions. You can put together a daily report card to identify target behaviors that need to be addressed and therefore manage them and then move on to other ones that have to be done. Some individuals talk about using technology, then there's various kinds of devices and techniques that state that they can identify individuals when they respond to medication, but that's only a response in the device. It's not a response in the real world. Feedback from the real world is usually more than sufficient for that kind of information. When you're looking at psychosocial interventions, we want positive parenting. It has been shown in research over and over and over again. Punishment, negative reinforcement, screaming, yelling, don't do anything for the ADHD child. These children are impulsive. They act before they think. So we may tell them what they should do the right way, but if they act before they think and they haven't developed that right way into a habit behavior, they're going to keep doing the same thing over and over again. If I punish you for doing something wrong and I don't tell you what to do that's right, I'll keep doing the wrong thing because I don't have any other script to follow. We know that there can be improvements in organizational skills, there are improvements in interpersonal relations, and in daily habits if this positive reinforcement, the positive parenting technique is used. We also have to manage the coexisting conditions in Tourette syndrome, especially the OCD and the anxiety disorder, which can negatively impact on daily functioning. From an academic standpoint, recognizing what ADHD individuals can do if we give them smaller work units, a set schedule so they know what's coming, longer time to do tests, shortening the amount of homework that they have to do, decreasing external distractions. One of my patients tells me that he takes exams in a quiet room with a longer time period to finish and is doing much better in the school setting, as well as making sure that the teachers and other school personnel know how to manage the ADHD, know and recognize what tics are, and therefore don't get freaked out when a child is having tic activity, and then reinforcing the positive behaviors we want. These individuals can do quite well. In all settings, structure, routine, consistency can be very helpful, as well as supporting what's called executive functioning, working memory, working on inhibition strategies, and the ability to be flexible to shift from one activity to another. If we're going to choose a medication for the management of ADHD, there are several options. There are the stimulant medications, there are the medicines in the antidepressant family, and there are what's called the adrenergic agonists, and I'll explain what each of these are. When we look at all of this, as far as we know, pharmacogenomic testing, which is all the rage nowadays, especially in the psychiatry circles, is not recommended for the management of ADHD. What does this testing do? It identifies how individuals metabolize or break down medications. But the data we have for the ADHD medications, especially the stimulant medications, is very limited and to date has not been helpful in terms of actually choosing the correct medication. And therefore, we should basically still follow the treatment algorithms as recommended in ADHD guidelines. When you look at the stimulant medications, which are still first-line medicines, even for individuals with Tourette syndrome and tics, and I'll explain why in a minute, there's basically two different families. There's the methylphenidate family, the Ritalin family, which is what racemic methylphenidate is, and dextromethylphenidate or dexmethylphenidate, which is Focalin. In the amphetamine family, there's dextroamphetamine, which is dexedrine. There's mixed amphetamine salts, which is Adderall, and there's lisamphetamine, which is Vyvanse. And there's a lot of other short and long-acting preparations that have brand names that I'm not going to go into today that can be identified. There's immediate release and extended release preparations depending on what the individual needs. When we look at side effects in this population, yes, some individuals do get side effects, but most of them tend to be temporary or transient. You can get a headache. There can be an abdominal discomfort, especially if you take the medication on an empty stomach, or you stop and start, and don't take it on a daily basis. So for patients of mine who come in, who basically say to me, every time I take the medicine, I get a headache, it turns out the majority of those individuals is because they're taking it sporadically rather than daily. It could hypothetically cause insomnia, but that tends to be temporary in the majority of individuals when that happens. Some individuals who get put on stimulant medicines can get moody. We know that in some individuals, the stimulant medicine can aggravate their underlying anxiety, so they get irritable, they get crabby, they get much more edgy, much more temperamental, much more explosive. You can have an increase in what's called picking behaviors. They basically pick at scabs, they pick at their nails, they pick at their cuticles, more so than we would typically see in the ADHD population. But this has to be differentiated from the I can't meet my hands still behavior of an ADHD child, or I'm very anxious and I got to find something to do in a child with anxiety. There is a concern about abuse and diversion, which I will talk about in a minute. And uncommonly, there's issues about growth, tics, and the risk of sudden death. But now let's go into a question and answer session here. Number one, before I ask you my true and false questions, the impact on growth. The research has shown that if an impact on growth occurs, it's a small effect. It's not usually a big effect. Some studies have suggested that there is some effect on growth. It might be a quarter inch. Some people say up to an inch. Other studies have shown that when you get through the adolescent years and by the adult years, you actually can catch up and make up for that deficit that occurs early on. Some patients may need to have medication holiday just so that they can eat and do well. But people have concluded that any effect on growth is far outweighed by the positive effect of the medication on attention span and the ability of the individual to do well with behavior and with learning. But now, let's get to our true and false session. These are excerpts from the packaged labels that come with these medications, with Concerta, with Focalin, and with amphetamine products. These are labels that have been approved by the Food and Drug Administration. It says about Concerta, it's contraindicated in patients with motor tics. Focalin, contraindicated in patients with motor tics. Amphetamine, been reported to exacerbate motor and phonic tics and Tourette syndrome. The question is this true or is this false? In today's day and age, when there's a lot of different reporting and stories, let's look at what this actually means. Early on, there were a few anecdotal reports of individuals that when put on stimulant medication, there was either the appearance or the apparent aggravation of tics. That was the basis for the Food and Drug Administration to put this into the package label. Since that time, however, research has been done that shows that there is no effect of that type, that there's no sustained worsening of tic activity in the vast majority of individuals who have both ADHD and a tic disorder. And that means that there's not the appearance of new tics, or there's not the aggravation of the underlying tic disorder. And probably the archetypal or the key study that was done was the Tourette Syndrome study group, where 136 children with ADHD and tics were put on combinations of medication. They were put on methylphenidate, a stimulant medication, which is Ritalin. They were put on clonidine, also known by the brand name of Catapress, or they were put on methylphenidate and clonidine, and some weren't put on anything. In other words, they were put on placebo. And they found that the methylphenidate was the best treatment for treating inattention. The clonidine did help the hyperactivity and impulsivity, but as you see the bottom of the slide, when there was worsening of tics in the three major study groups, there was no significant difference between the three groups. About 20 to 25% of each of the treatment groups, whether they got a placebo, which means no active medicine, whether they got clonidine or whether they got methylphenidate, out of all these groups, there was no significant difference, which means it doesn't seem to be in the population at large that there's any major signal that it actually worsens tics. When the FDA was asked about changing the package label, they said, we have no interest. That was done years ago by one of my colleagues. It should be changed, but it isn't. Is it possible that for certain individuals, the tics can get aggravated? The answer is yes, especially if those individuals also have coexisting anxiety, because we know stimulant medications can aggravate anxiety in some individuals. When anxiety is worse, tic activity may increase. But we also have to be careful that the tic activity isn't increasing, because that's just a natural cycle for that individual. Now, true or false? This is from an article in the New York Times. A statement was stated about stimulants like Ritalin or Adderall, that they can lead to addiction, anxiety, and occasionally psychosis. That sounds very scary. But again, true or false? For the most part, false. There was a concern that the use of stimulants might affect the developing brain in a negative way and increase the individual's desires to abuse drugs through the fact that dopamine is one of the neurotransmitters, one of the chemicals that's used in the pleasure center of the brain, known as the nucleus accumbens. And dopamine functioning is affected positively by stimulant medications, but studies in humans and beautiful studies in non-human primates, basically in monkeys, have shown that there's no increased rate of abuse of these medications. They actually gave monkeys a stimulant medicine at an appropriate dose for a year and then offered them drugs, basically abusable drugs, and the monkeys didn't choose them any more frequently than any other choice that they had that was there. There's no brain changes that occurred in the population. So for children who are on medication, there really isn't a significant risk of substance use. In fact, if they're not treated, individuals with ADHD are not treated, that's when you have the significant risk of substance abuse. The risk is much, much higher. If you treat their ADHD, it lowers the risk of substance use to that of the general population. And not only lowers the use of drug abuse, but also lowers the use of alcohol use and of cigarette smoking to that of the age-matched peers. Now, one of the things we do need to monitor is for diversion of the medication, not abuse, but diversion. In high school and college settings, most of the time the medication is being diverted not because people want to abuse it, because they want to stay up all night to study, because they have undertreated or underrecognized ADHD and have recognized that they need to have something to help them focus. But that's a topic for another day. For the issue of psychosis and mood issues, it is true. Stimulant medication can aggravate underlying bipolar disorder, and we can have individuals, for instance, if individuals are on a medication for tics, such as risperidone or haloperidol, and they abruptly stop it while staying on the stimulant medicine, there can be an aggravation of their behavior due to technical issues dealing with receptors that have now been unmasked and that the medication over affects. But the fix there is don't give it to people who you suspect is having bipolar disorder that is not adequately treated, and make sure that if you have to stop risperidone or haloperidol or similar drugs, you also stop the stimulant at the same time. There are medication side effects of irritability, moodiness, or dysphoria, and blunting of affect, And if it's too excessive, then the children shouldn't be on those medications. The young adults shouldn't be on it. The adults shouldn't be on those meds. Last point. Do these drugs truly cause serious cardiovascular events? If you read the small print here, it's anecdotal reports. It's just someone reported this happened, a few cases here, a few cases there. When this has been studied in large populations, they have found that there's no data to support the statement that there's an increased risk of sudden death or stroke in the population with ADHD who get treated with stimulant medication. There is an increase in emergency room visits, usually because of individuals who feel that their heart's racing very fast because they're on the stimulant medicine, because it can increase heart rate, but there's no identifiable increase in sudden death. There is a question about effect on blood pressure and heart rate and what it means. That is something that is being followed prospectively with answers to be provided in the future. There are other medicines that can be used for treating ADHD. In the antidepressant family, there's the tricyclic antidepressants, imipramine, nortriptyline, and desipramine. None of these medicines are as effective, as powerful as the stimulants, but can have a positive effect in circumstances where you want to use them. In the newer population, in the newer medication options, atomoxetine or Strattera is the only one that actually has an FDA approval for treatment of ADHD. But bupropion or Wellbutrin, venlafaxine, Effexor can also have positive effects due to the nature of these medications and how they work. These medicines can be chosen, and as I stated, they work about 2/3 as well as the stimulant meds, but can be very helpful for individuals who cannot tolerate or cannot get the stimulant medicines for a variety of reasons. There are more side effects. It can increase or decrease appetite. Most of the time, it decreases appetite. There can be lethargy, dry mouth, constipation. In individuals over 40 years old, there's urinary retention, especially in the men. There are potential cardiac effects from the tricyclics. Very rarely, liver problems have been reported on atomoxetine. It's extremely rare. And there are concerns that these medications can actually cause an increase in suicidal thinking. Extremely rare when this happens, and there's probably good reasons why that in the majority of individuals with ADHD we don't have to worry about. The third category is the adrenergic medications, clonidine and guanfacine. Clonidine is also known as Catapres or Capve in the immediate release and the extended release preparations. Guanfacine is Tenex or Intuniv in the immediate release and the extended release preparations. They can help improve attention, decrease activity. They can have a positive effect on anxiety. That's an off-label comment. They can help stabilize moodiness, especially when it's due to anxiety, and it helps them fall asleep. In fact, we use clonidine off-label quite frequently to help individuals with ADHD and other disorders fall asleep at night. Side effects are sedation and irritability. With guanfacine, there also is a side effect that's reported by some families of an increased appetite and weight gain. Even though it's not on the package label, this is something that is clearly reported by many families, and something to be aware of. So if you're going to treat this population, what do? Number one, you have to decide, do we need to use medication to treat ADHD in the Tourette syndrome population? You have to have reasons why you would want to initiate treatment. Are they at risk of hurting themselves, such as running into the street without looking for cars? Is there something that's straining family relationships or relationships with other individuals? Are they at risk for social rejection? Are they at risk for work failure or for basically academic failure? They're getting suspended at school. They're being put on probation for poor academic performance. The behavioral educational interventions have not worked, or they've got some coexisting condition that also needs to be managed. These are some of the reasons why you should consider the use of a medication for the treatment of ADHD. If you do use a medication, we follow a simple rule. You start with a low dose, you build it up slowly, especially in individuals with tics. And with the stimulant medications, some people believe that if you try to get the higher doses of the amphetamine products, that's when you aggravate underlying anxiety. That's when you aggravate underlying tics. So lower doses can be helpful and effective, higher doses can actually lead to problems. This is less risky, but still possible with the methylphenidate products, the Ritalin products that are described. Now, stimulants are still first line, whether we're dealing in the vast majority of individuals who talk about the treatment of ADHD in individuals with Tourette's and tic disorders. Tamoxifen and the alpha agonists can be used for individuals who don't show a good response to stimulants or have side effects from the stimulant medications. Sometimes if you add tamoxifen to a stimulant, you add either clonidine or guanfacine, short-acting or long-acting to a stimulant, you get a bigger bang for your buck, such as has been shown in the Tourette Syndrome study group study. When there's a concern that there is going to be an aggravation for tics, then you go with the non-stimulants. If there's a serious concern that there's going to be a potential for drug abuse, you go with the non-stimulants. And you monitor for some of the side effects as I had mentioned them. So the goal of our therapies in this population is to control the ADHD, avoid aggravating the tics, avoid aggravating OCD, avoid aggravating anxiety. If you can put them on all-day therapy, that is optimal. There are cost issues involved in some of these decision-making processes, but individuals with ADHD sometimes forget to take their second or third dose if you're putting them on a short-acting medication, because we know that the extended release preparations give you more even blood levels throughout the day. And we also know that medicine for ADHD, while it may improve attention, reduce impulsivity, and reduce hyperactivity, does not teach you how to behave, does not teach you how to learn, does not teach you how to socialize. So you need the appropriate educational, behavioral, and psychosocial program in conjunction with the medication in order to achieve an optimal outcome. This is a list of some resources about ADHD if anyone has them, and I'm happy to answer questions at this time.
Thank you so much, Dr. Wiznitzer. So as he mentioned, we're now going to begin answering the questions that were submitted during tonight's presentation. As a reminder, you can still submit your questions through the question pane in your control panel. If we are unable to get to everyone's questions, here at the TAA, we do have a full-time information and referral staff who can answer your questions as well if you email support@tourette.org or call 1-888-4-TOURETTE. So, Dr. Wiznitzer, the first question that we have, what kind of doctor should we see to diagnose Tourette's, and what questions should we ask them?
The simple answer there is a doctor who understands Tourette syndrome. Most of the time, when it comes to tic disorders, it's going to be a neurologist and developmental behavioral pediatrician as the specialists who probably see most of those individuals. Some psychiatrists also do. In my medical center, the psychiatrists, for the most part, refer to the neurologists in order to diagnose and manage the tics. And the questions that we really should ask, it's not really the questions that should be asked, it's the questions that should be asked about this, which includes what kind of tics are occurring, when they're occurring, how they're occurring, do they fluctuate over the year, the impact of the tic activity, are the tics causing any impairment in socialization, are they causing any physical problems in that regard? Those are the kind of things that the physicians want to know in order to identify that the tics are there. Now, tics, we have to get good descriptions. The nice thing about modern technology is almost everyone has a phone with a camera. If an individual has a movement about which there's a concern, make a video of it, show it to the treating physician and say, what do you think? Most of the time we can call it a tic, but there are other movements that can mimic tics and need to be sorted out because the management is different.
Great, thank you. So the next question that we have, someone is asking, sorry that if they missed this in the beginning, however, does everyone with Tourette's have ADHD, or can you have just Tourette's by itself?
The answer to that is about 30 to 90% of the Tourette syndrome population also have ADHD. Depending on the individuals that are monitored, and where you're grabbing them. For instance, if you go to a clinic at a hospital where the more severely affected individuals tend to be referred, there's a higher rate of ADHD. If I go to a general pediatric practice, it's probably a lower rate. So the answer to your question is yes. You can have Tourette syndrome independent of ADHD, just like you can have ADHD independent of tics.
Great, thank you. Next question. Why does it seem so difficult to determine what is ADHD and what is mood related and what to treat first? Is there a specific approach to figuring out where to start?
Yes, there are actually criteria for mood disorders that can be identified. One of the reasons that mood lability is not a part of the diagnostic, or mood impulsivity is not part of the diagnostic criteria of ADHD, is because people were concerned that there would be confusion in the diagnosis. What you can identify for ADHD is, while an individual may be moody, but it's usually related to the impulsivity. If for an ADHD individual, if things are going the way they want, they're behaving fine, they're happy, they're doing well. When things don't go their way, there's a subset of those individuals who really don't do well with transitions, who don't do well with unexpected change, who basically have behavioral inflexibility, and they're the ones who are going to be overreacting. Now, that's different than individuals with primary mood disorders, that no matter what the environment is like, the mood disorder will be symptomatic. I hope that answers, that hits the key point of what the question is. But the diagnostic criteria in and of themselves can easily sort it out when you identify that the ADHD features are the core problem that's there, and the mood lability is just a component of the ADHD, versus the mood disorder is the prominent problem, and the inattention is related to the fact that my mood disorder is distracting me.
Great, thank you. Okay, so next question. I see a lot of pediatricians putting pediatric clients with TS who may or may not have ADHD on clonidine and guanfacine. Is that typical practice?
Yes, that's to put them on clonidine and guanfacine. It is a practice that can be done most of the time if you pay attention to the individuals. If it's the first medicine that's chosen, and maybe that we're treating a preschool child, although there are good data that tell us that the use of a methylphenidate or Ritalin product in the preschool years can be quite effective in the management of ADHD. But some individuals feel uncomfortable using the medication at that age, and they'll try a clonidine or guanfacine product. But if you have an underlying tic disorder, the idea there is treating them with clonidine or guanfacine products basically may address both the tics and the ADHD. So basically, you're killing two birds with one stone.
Okay. Okay, let's see. Next question. How often does OCD occur with ADHD and Tourette's, and what should we look for to diagnose the OCD? What age does OCD usually develop?
Well, there's a difference between what age OCD develops and what age it's recognized. Only half the individuals who are symptomatic as children get identified in the childhood years. That's been shown in some of the research work. Hopefully the numbers are improving with the greater identification of this population. You can have OCD behaviors in the preschool years if they're above and beyond what you normally would expect, but normally the OCD behaviors are more recognized in the childhood and the adolescent years. It occurs in a strong percentage of the Tourette syndrome population, depending on the studies that you look at. Some people quote numbers up to about 50. Let's say take a number of about 50% of the population may have that. But it's a more complicated answer, because if we look at family units of individuals with Tourette syndrome, you may find someone with just Tourette syndrome and a first-degree relative, a parent or a sibling, with just OCD behaviors as the prominent features that are there. OCD has diagnostic criteria that need to be met that we don't have time to talk about today, but they're easy to access. For instance, information can be available, I'm sure, through the Tourette's Association, as well as the OCD Foundation, if you want to look up the specific criteria. And the important thing to remember is, as I was talking about the ADHD features, as they fluctuate over the lifespan, and they may manifest subtly differently depending on if you're 5 years old, 15 years old, or 25 years old. In the same way, OCD behaviors may show themselves differently if you're 5 years old, 15 years old, or 25 years old.
Great. So someone has a question to build on the one you just answered. There appears to be a lot of overlap between ADHD and OCD. Example, impulsivity and moodiness. What are the key differences, and are the treatments similar or different?
The treatments are different, and while you're saying superficially the impulsivity and moodiness is present, what you have to ask yourself the question is what's driving those behaviors. I tell that to my trainees all the time when we see a patient. It's not enough that you have a runny nose. I need to know why you have a runny nose, because otherwise I might put you on the wrong treatment. So the impulsivity and I said, let's turn around. The moodiness in OCD is related more to the fact that if things aren't going the way I expect them to go, if I'm a perfectionist, it stresses me so much and makes me so anxious that I can get temperamental and moody. The moodiness in ADHD can occur in individuals who are inflexible and perhaps not getting their needs met. I want something and I nag you for it, and you don't give it to me, and therefore I'm irritable, moody, and grumpy about it. So there's really two totally different origins for why these behaviors occur. The impulsivity, again, it tends not to be as much of a core feature of OCD. Impulsivity is more of the ADHD, unless the person with OCD also has some ADHD within there. And of course, the treatments are totally different in terms of managing the ADHD and the OCD.
Great, thank you. Okay, so next question. My son, 8 years old, who was 5 at the time, had a terrible reaction to both Concerta and clonidine. Both caused terrible tics, and in fact, he was incapacitated and unable to talk. Ritalin is fine, however, we need longer hour coverage, but not causing appetite suppression, and also to help with the tics. Do you have any ideas?
I try not to give general medical advice
Okay.
when I don't know all the facts, but let me just give you a general idea or picture.
Okay.
I think that questioner raised a very good question, which is if you don't do well on one extended release product, one extended release stimulant product like Concerta, should you give up the ghost on all the extended release products? The answer is no. I have patients who do not tolerate Concerta, but do quite nicely, for instance, on methylphenidate or Metadate CD, or might do much better on Quillavant or Quilichew or other brand name products that are there. So it seems to be that certain individuals do better depending on the delivery system, because after all, Ritalin is the core component of Concerta, and I was just told in the question that the child is doing okay on regular Ritalin. There are some people who say that if you use a medication such as dexmethylphenidate or Focalin, it may have less of an effect on appetite because you're getting exposed to less of the medication. It's a possibility and something that should be considered. But in these circumstances, you basically have to work your way through the various options of treatment until you find something that really syncs well with that individual.
Great, thank you. Okay, next question. When a child has Tourette Syndrome and ADHD, which one should I consider as the principal diagnosis to start the treatments?
The one that's causing the greater impairment in daily functioning. Seriously. When I talk with parents and the children may have 2 or 3 problems, let's assume that I've got another example would be if I've got a child with ADHD and anxiety, I basically say which one's impacting the child's functioning on a daily basis to a greater degree. And those are the ones that basically we will address first. Now remember, with tic disorders, there's an armamentarium of treatments, just like I talked about with ADHD, that include medications as well as non-medicine approaches. And we try to stress the non-medication approaches, using the habit reversal or CBIT therapies when you're able to access a provider for that and when the child is old enough to learn it. But at the bottom line, you have to ask yourself what's causing the greater problem, and that's what you address first.
Great. Okay, we'll take one more question. How long should you wait to see an effect in medications?
Thank you for that question. I forgot to say that. I appreciate that someone asked me that. With the stimulant medications, you basically, the effect should be noticed from the first time you dose it. And the only reason that you increase the medicine slowly is to make sure that the individual tolerates it and gets used to it, so that you can build up to the next dose as you work your way up. And there are calculations for children on doses on a per weight basis. When it comes to the non-stimulant medications, atomoxetine or Strattera, clonidine, or guanfacine, which is also 10x, you have to wait weeks before you see the full effect. Most of us state that you got to give it about 4 weeks or so to see the effect of whatever that dose is before you move on to the next dose. And again, you start low and you go slow and you build it up. For instance, with atomoxetine or Strattera, there's about 7 to 10% of individuals who slowly break down that medicine in the body. If I start them on the recommended dose, which is about 1 milligram per kilogram per day, they're going to sleep throughout the entire day. So most of us start them on a small dose, a low dose, see how the individual tolerates the medication, give them a few weeks on that, and then gradually build up on that medication, knowing that it takes weeks to see the full effect.
Wonderful. Thank you so much. So thank you again for a wonderful presentation, Dr. Wiznitzer. This is all the time that we have for our webinar. If we didn't get to your question, as I mentioned before, please feel free to give us a call or email support@tourette.org, and we would be happy to answer those questions for you. As a reminder, once the webinar is closed, you will receive a survey on the presentation. We would greatly appreciate it if you would please complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of tonight's webinar if you would like to watch it again. Additionally, the webinar will be posted on the Tourette Association YouTube channel for those who were unable to participate today. On our YouTube channel, there are previously recorded webinars that we have done in the past, so please check those out as well. We encourage you to reach out to us on social media about this webinar or for other ideas and suggestions that you may have. So on behalf of the Tourette Association, thank you again for joining us and taking the time to view our presentation. Have a great evening, everyone.